This is PT Pro Talk, the podcast for physical therapists who want to improve their clinical skills and be more successful. I am Mariana Parks, physical therapist and your host, and today I bring you my conversation with Scott Herbowy to discuss the management of extremities using the McKenzie Method. In our discussion, Scott will talk about the key aspects he focuses on during the subjective and objective examination of extremity patients, including how symptom location and the consistency of symptoms help in diagnosis, the most common directional preferences he finds in extremity derangement patients, insights into the types of forces and load strategies he uses, the combination of movements in different planes, and his rationale behind these treatment approaches, insights into contractile dysfunction and strategies for managing this classification, and common mistakes MDT therapists often make. Scott has 4 years of experience in mechanical diagnosis and therapy, the McKenzie Method. He began training personally with Robin McKenzie in 1984 and continued his training directly with Robin until 1992. Scott became a McKenzie Institute instructor in 1993 and has since then presented over 500 continuing education courses across the US and internationally. He was also one of the first instructors for the Institute's inaugural standalone extremity courses in 2001. At the personal request of Robin McKenzie 15 years ago, Scott helped develop and mentor physical therapists worldwide through a 360-hour clinical training program known as the Diploma Program. If you find our conversation interesting, I encourage you to subscribe to our channel, hit the notification bell for updates, give us a thumbs up, and share this episode with other colleagues who could benefit from our insights. Thank you for tuning in, and let's dive into the discussion. PT Pro Talk is only possible with the support of the forward-looking and innovative companies like Sarah Health. Remote therapeutic monitoring sounds great, but also difficult. Sarah Health makes RTM simple and easy for your patients and providers. Check out sarahealth.com/PTProTalk for a special offer.
Welcome to Urban Polling. Discover the Activator program and polls for rehab and balance.
Hi, Scott. Welcome to PT Pro Talk. How are you today?
Good. How are you?
I'm doing well. Excited to have you here with me and to learn a lot with you. So let's get started talking a little bit about yourself and your background.
Okay. Well, I'm old. I've been around a while. I was fortunate enough to run into Robin, take my first class with him just a couple of years out of university, and up until that point, I had been taking a lot of different courses. I took courses with Stanley Paris and other courses, and I was always continually frustrated that the things that I would learn at these courses, I had difficulty applying. And then I went to a class first. I read the Treat Your Own Neck and Help My Own Neck, which I hadn't been able to help, and was amazed that within just a few days, my neck pain that I'd had for about a year was much, much better. I then was able to get my hands on Robin's original textbook, which you got to remember, this is before internet, before you couldn't just Google and find out where to buy it on Amazon. It was a much bigger effort, and information was much less readily. So I did get the book, and then saw that he was teaching close by subsequently, and went to that course and had an awakening, like most of us did when we saw these things. And Robin's course then was, it was part A, and he talked literally for 45 minutes, and then he started seeing patients. And he saw, I believe on the course I went to, I think he saw 16 patients over the course of 4 days. And a lot of the time I had no idea what he was doing. And that was the thing about Robin back then. He assumed most people knew what he was doing, when in reality, very few people had any idea what he was doing. So, but I did see enough, and I can still remember some of those patients, enough amazing things that I went back to the clinic and literally would take the book in the room with me and try to apply these things to the patients. So I continued my training. I spent time quite a bit of time with Robin. I was lucky when I was at my diploma program in 1992 that he had the Lodge, the chronic pain program going, and we each got to spend quite a bit of individual time with Robin. Weekends, because the program ran 6 days a week, so he always needed help, he said, on Saturdays. So I always volunteered. I thought, yeah, I'm in New Zealand, and one of my partners went sightseeing every Saturday, and I thought, well, I can go sightseeing anytime, but what are the what's going to be the opportunities to spend all that individual time with Robin? So subsequently was appointed U.S. faculty, international faculty, and shortly after I came back, I believe 1 year later. So I've now been faculty for a little over 30 years and have taught probably over 500 courses. And without trying to sound self-promoting or egotistical, I think I've taught more extremity courses than anybody, simply because in the U.S. We have more opportunity. There's that many more of them. Plus, I've taught a bunch of them international as well. And my philosophy on this was Mark Miller and Colin Davies and I, who came back and were charged with developing the extremity course for North America. And our thought was, well, we're going to do a day and a half. We're going to go back to roots, meaning we're going to see lots of patients. And these are people post-Part D of many credentialed. So we're going to assume a basic, foundational understanding. So we're not going to spend time didactically with a lot of lecture. We're going to see patients. And that model, I still use that model to this day for extremity courses.
And when was the first extremity course?
I believe it was in 2001, and neither Colin, Mark, or I had enough guts to do it solo. So the three of us did it. It was a challenge then. It was because there was not only the challenge, and there's been an immense learning curve. I mean, I look back at some of those early extremity courses and I say, oh my gosh, I'm embarrassed. But you gain that collective knowledge over time. But it was also at that point, remember, Part C and D had no mention of extremities at that time. Mm-hmm. So the thought, and it was very interesting because when we first did the first course in 2001, the first couple of courses were widely subscribed. They were oversubscribed. They were sold out. And then we start seeing this drop off, and we were puzzled. And I remember Colin, Mark, I, and Stacy had a call together, and we came to the conclusion that many of these people, there was a pent up demand, and that got filled. The people who are very, very bought into the system wanted to see it. But then once you get beyond that, we're trying to talk to students about extremities who never heard one mention of extremities through mm-hmm. Part A, B, C, and D. And so there was just, there was the learning curve on our end, but there was also that skepticism and really skepticism on the part of the students as well, going, well, and remember the DISC model, which personally I think is still a very valuable clinical reasoning tool. It's not something I discuss with patients, but it's in here when I'm examining patients. Mm-hmm. That was very widely promoted. So, the thought by most people, well, this works on the disc and there's no disc in the extremity. So how in the world could this stuff work?
Mm-hmm. Yeah. And over 20 years of experience then teaching extremities, I bet you learn a lot.
Yeah, and again, the last course I taught earlier this year, the last extremity course, I think I saw either 8 or 9 patients on that course, and my entire career, and it happened not in an extremity course, but a course last year. And Stacy even called me. She said, "I've never seen anybody ever say this on a course evaluation." The person remarked that we saw too many patients. And that's just, 99, what used to be 100% of the time, people always would say, I want to see more patients. And this individual said, oh, I didn't like the course because there were too many patients, which, yes, Stacy, she even called me. She said, it's 25 years, I've never seen anybody say that. So by and large, and that was Robin's philosophy. He said, the only way I can demonstrate these things is by showing the concepts with patients.
Yeah. And how many years of experience in McKenzie? So since the beginning until today, how many years that you've been in the system?
Basically 40.
Oh my goodness. That's a lot.
Yeah, that's a lot.
It's more than what I'm alive.
It is, and it's amazing what I'm teaching now, and I guess it will happen to everybody at a certain point. You make references or comments, and the whole group looks at you like they have no idea what you're talking about because you're referencing something, just something that a lot of the older folks that might hear this, Williams flexion exercise dominated spine care in the 1950s, 60s, 70s, even into the 80s. I know in the U.S. and I think probably in a lot of countries. And now you make that reference, and probably at least half the people in the room aren't even familiar with that term. So
I remember the William flexion and the McKenzie extension. Like I remember briefly the names, but had no idea what it was.
Right.
At that time.
Right. So it's interesting. So you take that with a little bit of grain of salt and say, okay, well, shift gears, but the benefit of 40 years is just seeing so many patients. And Robin talked about that. The first anterior derangement or lordotic deformity he said he had been treating the woman for a couple of weeks with no improvement. He'd been extending her, and then he was about to give up, and he thought, well, what I got nothing to lose. I'll give her flexion. And she got better very quickly. And he thought, what is this? And then he said a few months later, he saw another woman. And as he was treating her, he thought, wait a minute, she reminds me of that last woman. So he flexed her and he got better. And he said, I'm sure there were many others that I missed, but then I started to identify it and know. And that's what it is. It's pattern identification.
Yes. And what a privilege to have all this experience with McKenzie. I just imagine, all these years that you had with him. So amazing.
Yeah, I feel very fortunate. Mark Miller's vocal about it. People say, "Well, you were lucky to spend time with Robin," and Mark says, "Well, I was smart enough to hitch my wagon to the right horse." So because there were a lot of people out there that were available. I took classes with Maitland, with Paris. I took classes with Mulligan, and I do use some of those things, but that I learned, but I use it within the framework of MDT, because that's the one thing, having looked at a lot of different approaches, that the MDT evaluation and examination is comprehensive and it's reproducible. I talk to patients or students on Part A and say, if you follow these principles and we both see the same patient on Monday, we will get the same answer. The only difference being I will get it more quickly based on experience, but you should get to the same point if you follow this. So that speaks to it. I had a patient that I saw not long ago who was from France, and I began the treatment, and then she went back to France and she saw an MDT person there, and she sent me an email and said it was amazing to me as a scientist that I could have treatment here or go across the ocean and the treatment was the same. It continued the same. It didn't deviate. So that's such a strength of the system, the reproducibility of it.
Absolutely. And now moving to the extremities, that's going to be our topic. So talking about the subjective history. So what are the important things that you pay attention to when you are screening a patient?
Yeah, there's a few things. I mean, obviously the extremity evaluation form is similar in format to the spine. And even in the spine, I mean, my focus, I know Robin, I heard him say a number of times, I think the most important thing you ask people is whether the symptoms are constant or intermittent. And not to say that that's not important, but to me, the most important thing with all patients is symptom location. Symptom location helps you differentiate spine from extremity. Symptom location can help you differentiate in the extremity derangement versus contractile dysfunction. Contractile tendon tissue, the pain is very, very, very local. It's very small. It doesn't radiate down the arm. So if somebody truly has a tendon problem, the pain should fit under a large coin. And if it radiates down the arm, you can't. Oh, you can never say never, right? But that decreases the likelihood. So symptom location is key. And if you look at the follow-up to the Expo study, one of those criteria was the presence of paresthesia. So people come in and say, I have a shoulder pain. You have to make sure, well, do you happen to have any numbness or tingling in that extremity as well? So those little things you need to make sure that you cover. Derangements in the extremities, in my experience, unless they're acute, are rarely constant. When somebody comes in and says, I have constant shoulder pain, I'm sitting here at rest and I have this pain. I saw two patients this week, came in, constant shoulder pain. In both cases, it turned out to be the cervical spine. So derangements in the extremities, by and large, are intermittent. They will hurt with movement, but they typically don't hurt at rest. Again, unless very acute. And in the extremities, the better worse section, you rarely get indications of directional preference. You get descriptions of worse. I always give the example: what hurts your knee going up and down stairs? What makes it better? Using the elevator. They don't really describe better other than avoidance of the aggravating activity. So it hurts when I throw a ball. What makes it feel better? Well, if I don't throw the ball for a few days. So it's not as clear as the spine in getting good information on directional preference. But what's important in that better or worse also is to because in my experience, I was a diploma mentor for 16 years. Probably helped train well over 100 diplomats, and there were certain areas that most of them needed improvement. And it was interesting because it didn't matter if you did your courses in France or Brazil or Japan or the U.S. The areas that people needed help in was fairly consistent. So, I think that might reflect back, and we should maybe look at that and see, does that reflect back on our teaching? But anyway, one of the things that people would struggle with, they could take a nice history, but then they had trouble using that information to help in the assessment process. So in the extremities, most people look at, well, better standing, walking, worse sitting, bending. Oh, they don't like flexion, they like extension. But there's more to it than that. Is what's the type of force? Is it sustained force? Is it intermittent force? Is it weight bearing? Is it non-weight bearing? Is it ballistic? And all those things come into play in extremities when you're going through evaluation and management. And a lot of people, again, take the history and then kind of forget about those things when they get into the exam.
Mm-hmm. And going back to the constant intermittent, so if the extremity has constant pain, it's not likely to be a derangement extremity, but it could potentially more likely to be a derangement in the spine.
Well, yeah, I think we need to be careful what word likely. As my experience is, more often, if it's constant, it's probably coming from the spine. It's not, I don't want to give people the impression that, you can never have a constant shoulder pain associated with a shoulder derangement, because that's not true. And again, I don't have hard evidence. It's just anecdotal. Most of the time, extremities pain is derangement. Extremity pain is intermittent.
Mm-hmm. And when you say the location helps you to differentiate between spine and extremity, could you give us like an example?
Yeah, shoulders, an easy one. Shoulders generally will not have intrascapular pain. Intrascapular pain, that was first studied and published in 1959. Cloward looking at in vivo mapping of pain from somatic structures in the cervical spine, and we have all heard patients come in and go, "Oh, it's this spot, it's this spot, it's this spot." That's clearly, and that was reproduced by Charlie April, I believe, in the 1990s. Those are Cloward signs, and if people don't know what they are, I would encourage them to Google that and look that up. That is exclusive to the spine. The shoulder doesn't hurt back there. The hip. Most patients think their hip is lateral, but your hip joint is anterior. And people say to me, "I have a hip problem." My first question is, "Do you have groin pain?" Groin, posterior buttock. Now, that's not to say you can never have lateral pain associated with the hip, but when they tell me it's lateral, I'm more skeptical it's hip, and more. I might look at the spine a little bit more thoroughly versus somebody comes in and points right to their groin and says, "Yeah, I've got this pain here," and then you start moving it, and you see large loss of motion, reproduction of pain when you're moving the hip, and again, that pushes you toward the hip.
Posterior pain as well? More
buttock pain, it'll be sometimes it's groin, posterior buttock. It can kind of wrap around going from front towards the back, where lumbar problems tend to start posterior and move towards the front. So the hip will give you pain radiating back posterior. The back will give you pain radiating lateral and anterior. And none of these are 100%, but those are things you look at. You combine, the symptom location with some of the behavior. Hips, for instance, again, you don't get a lot of directional preference, but hip derangements, rising from sitting, might bother them, but it's that first few steps. And that's the same with knees, that first few steps. So you start to get a picture as you go down the history. Okay, I've got this groin pain. It's bothered by the first few steps. Wow, that's sounding a lot like a hip. Versus I've got lateral hip pain and it hurts rising, but I don't really hurt walking. You go, "Oh, that sounds to me much more like a spine problem."
Okay. And then going towards the examination. So what are the important things that you pay attention when you are doing the physical examination?
Well, first of all, movement loss assessment is so in my mind terribly important in the extremities. If you look at the papers on prevalence of derangement and dysfunction that originally published in 2006, and the findings were about 40% dysfunction and 20% derangement. And I remember that came out, Miller and I talking about it, and we were kind of confused. We were like, "Boy, we're seeing different patients. I don't know. We see a lot more derangements." And 6 years later, 2012, another paper came, prevalence, and the figures had turned completely, 40% derangement, 20% dysfunction. And we think that the reason for that is people start examining, and you must assess movement loss in the extremities using passive overpressure. It's just critical. You don't find the movement loss in a lot of cases. Movement loss in the extremity associated with derangement can also often be very subtle, and you don't find it until you add that overpressure.
And anything else on the examination before we move on?
Well, yep. When you don't find movement loss, then you've got to be more suspicious of it. My mindset when I'm seeing an extremity patient, ruled out the spine, I'm just thinking one of two things: is this contractile or is this articular? Really, that's all it can be. It's how the joint is behaving or how the tissue around the joint is behaving. That's really the only thing there is. Assuming there's no systemic problem or something like that going on. But that's what it is. And if it's a joint problem, it's movement loss. If it's a contractile problem, again, you can have articular dysfunction with a loss of motion. But those are clinically becoming increasingly uncommon. I'm old enough to know to remember that when I got out of school, I literally probably spent 2/3 of my day pushing on stiff joints. And that's because then, no matter what you had, likely you were put in plaster for 6 to 8 weeks, which was a devastating thing really to do. If you've never seen a knee immobilized at -40 for 8 weeks, you can't believe the actual devastation that occurs to the entirety of the limb. That takes, in many cases, it never fully recovered. But fortunately, you don't see many articular dysfunctions anymore. So if you're looking at the extremities, it's articular derangement, it's contractile or tendon contractile dysfunction. And contractile dysfunction typically has no loss of motion. Patients will describe stiffness, but it's not a true loss of motion. And when you find that presentation, you have to assess resistance through the entirety of the range, looking for that pain during movement associated with contractile dysfunction. It's not a strength assessment. So you can't do just a break test of the joint. You have to again resist movement through the entirety, looking for that, and that's something to be aware of.
And then for the derangement, you have to find movement loss for the extremity.
Yeah, and movement loss, it's the same. I think our definition says there is typically loss of movement, and I think that's a nice way of saying that there's probably movement loss, but sometimes it's not identifiable. If you see somebody that is very, very flexible, you can certainly imagine they could have a 1 or 2% loss of movement that you might not be able to detect. In my mind, derangements have movement loss. And I think it's at a high enough identifiable percentage that I'm comfortable with that statement. Have I ever seen somebody that didn't look like they had movement loss and turned out to be a derangement? Yes, but I think those are far and few between.
Okay. And then in your experience, a lot more derangements, right, than contractile dysfunctions?
In the extremities, yes.
Yes.
Yes, by far.
And very few articular.
And these days, fortunately, very few articular, because people are not generally immobilized. The new thing, peace and love, protect, elevate, avoid anti-inflammatories, compress, and exercise for acute injuries. So get the thing moving, quickly, not absolute resting it.
And anything else, Scott, examination-wise?
No, I think that, obviously, that it goes without saying. I mean, you have to rule out the spine, so at least you get your baselines in the spine. I think, there's some suggestions. I'm not sure if they're calling them guidelines that have been put out for ruling out the spine. And I think you can't be dogmatic about it. I think it's a very individual, and the guidelines do say that they should be, these suggestions should be applied individually based on a number of things: patient's expectations, the patient's beliefs. If the patient just saw an orthopedic surgeon who said, "This is your knee," and had an MRI of the knee, and then we come in and ignore the knee and start doing lumbar extension, that can be a problem. Even if it's clinically correct, that can be a problem. So you have to have that balance initially, and confidence in where to go, but also confidence in that, I did go to the knee and it didn't work out. Well, I can still go to the spine as long as I know that have that as an option. It's okay. No different than if I went to the spine first and then it turned out to be the knee. So often it's not just a fork in a road with 2 choices. It's a fork in a road with 4 choices, and you don't know which one of those 4 is going to be the best. But what you really need to know is that you have those 4 options, because you can systematically go through them and test each one.
Mm-hmm. Okay. And now let's try to do a quick summary of each extremity. So like common directions that you see, and then the challenges, the different ones that we don't think about.
Yeah. So I think an easy way to do it, and when I teach, say, look at the elbow and knee are brother and sister, and the parents are the spine. They really do behave, and you can examine them with the same mindset in that you start in the sagittal plane, knees and elbows, flexion extension, just like the spine. And then you have the possibility of identifying the need to go lateral. And the same thought process. How do you end up knowing you need to go lateral in the spine? Well, two reasons. If everything sagittal is worse, you've got to go lateral. Or if you've gone sagittal and you've improved, but you're plateaued and you've gone through progressions and force alternatives and you're not still getting further improvement, then you need to go lateral. And I think that applies precisely to the elbow and the knee. And in both those areas, the most common directional preference is extension. And then I would say second is actually not flexion. Second, it would be extension with some sort of lateral force. And I find myself doing that more than say, I'm flexing a lot of elbows or flexing a lot of knees. Mm-hmm. Shoulders and I guess I'll speak in a little bit about the thought I was going to put out there, but excuse me, shoulders and hips are brother and sister, but they don't behave like the spine at all. You're not going to go in there straight with flexion extension and use a lot of lateral movements in the shoulder and in the hip. And I would encourage people, they don't have to do it the way I do it, but because of the ball and socket presentation with just almost infinite variables, meaning I can do horizontal adduction from here, I can do it from here, I could do it from here, I can do it from here. I think you really need to pay attention to how you're doing it precisely, because if you don't, and one time the patient's here, one time they're here, you can get a widely different result. And if you're not paying attention to it, you don't have a baseline from which to work with to explore force alternatives, for instance, more flexion or less flexion with horizontal adduction. So the ball and socket joints in the examination, and I think in the management, I'm very, very careful to pay attention to the exact starting position, how they move to stay on plane, and again, making sure is always that they're getting to end range evidenced by strain or pain. So those things you really need to pay attention to. Everybody, I think most people are familiar with prevalence for extension and internal rotation for both the hip and shoulder are very high, and I don't deny that. But I do in the shoulder do a fair amount of horizontal adduction. I also do a lot of eccentric loading of end range elevation, either abduction or flexion. In the hip, we use a lot of ballistic loading. We go to that fairly quickly, which makes sense because big, strong, weight-bearing joint that you run up and down a set of stairs, that's ballistic. You play basketball, that's ballistic. That's what that limb is built for. I found myself doing, I think, increasingly more a deduction in the hip as well, besides internal rotation and extension. So those are some of the things that people can look at and explore and gain that knowledge and confidence after they've seen it a few times. And things just to remember that, internal rotation extension didn't work. Oh, should I give up? Should I flex it? Or should I, start to try to turn this into a spine when it's really still the hip.
Mm-hmm. Okay, many questions. So how do you do the adduction? You
get down, if I can point my camera, let's see if I...
People can watch on YouTube for the ones that are just listening.
You tell me if you can see. So get the patient down. Is it okay?
Yes, I can see it.
The left hip would be the problem hip. Excuse me. The right hip, I'm very bad with rights and lefts. You need to have some sort of support on that side. Patient stays upright and then comes across like so.
Okay.
They have to get strain on that hip. You can combine this adduction with extension as well.
Oh, okay.
So the position and the extend.
For the ones that are not watching, he's just doing the half kneeling position and then shifting the weight to adduct the hip. You can check on YouTube later.
Adduction actually makes a lot of sense because, what do we do with our hips all day? We flex, externally rotate, and abduct. And often, why do we use so much extension in the spine? Well, the theory is because we flex so much. And you can apply that reasoning to the extremities, and it works the same way. What do we do with our shoulders all day? We elevate, externally rotate. Well, extension, internal rotation, but we also do a lot of abduction.
Yeah.
Hence horizontal adduction, the opposite.
Yes.
So these things make perfect sense. And then when you start to combine movements, you can vary it in an almost algebraic sense, come up with progressions. So for instance, if I start with shoulder extension and the joint is positioned with palm up, which is internal rotation, I get a partial response. Then if I go, let's say I get a 30% improvement, plateau, well, then I look at internal rotation and they're actually worse. That would tell me, okay, this joint likes extension, but it doesn't like internal rotation. So now I would do my extension and put the palm down, meaning putting it in external rotation. So you can figure out these force alternatives, especially in the ball and socket joints and it does apply to the spine too when you're talking about lateral, but you can figure these things out very logically. And when I teach it, I say this is just like algebra. This if you subscribe to it, and I got a mind that's very left brained and works like that, so it works perfect for me. But I think there's just in most cases, just if you really think it through, it makes so much sense.
And how about the ballistic loading on the hip? How do you do that?
We'll use ballistic in the hip. I'll use ballistic in the elbow. I use ballistic in the shoulder. Ballistic certainly in the ankle and knee. I think the first thing to say about it is it's typically never a day one loading strategy. This is the patient's, 50% better and it's plateauing, 70% better and it's plateauing. I mentioned using resistance for elevation in the shoulder. So the patient's 90% better, but they still have a little bit of pain right at the end of elevation, which is not an uncommon, but they've cleared their extension, cleared their internal rotation. That's not an uncommon presentation. And one of the best ways to approach that is small, eccentric right at the top in whatever plane is still problematic. But then you can start with slow eccentric, but then progress to that last little bit with quick eccentrics. Essentially ballistic eccentrics. That's not going to be a day one procedure. That's down the line.
Okay, and then you use bands to resist. How do you do it?
Typically, I like to use TheraBand because you can find whatever angle you want. Elbow ballistic is just throwing the elbow out, we saw, I give this as an example, we saw on this last extremity course I did one of the participants who 52 years old, and he hurt his elbow when he was 12 years old, and he still had a problem with it 40 years later. And he hurt it throwing baseball. And he said, he was a participant on a course. He said, yes, I think it's dysfunction because if I throw, it hurts. I have pain at end range. And on examination, he did have limited and painful end range extension, but he also had limited and painful end range flexion that he wasn't really aware of. Now, that still could be dysfunction, but as we start working him into extension, he had very, very, very severe pain in extension, which was pretty consistent, but his flexion improved. Well, that can't be dysfunction. And we worked on that, continued on that. Flexion continued to get better. Extension wasn't improving. And then if you look at his history, there was the answer. How did he get the problem? Because we did a lot of reps, we did sustained, and again, that all improved the flexion. Didn't really improve the extension. You look at his history, the onset was throwing, which was ballistic. So then we went to ballistic extension, which was very painful to begin with. But as he did 8 or 10 reps, it started to feel better, to the point where it really didn't hurt, and he regained his extension. So the history is what told us what loading strategy was going to be appropriate, for his derangement. And he was quite surprised because he thought for sure, well, 40 years, this has got to be a dysfunction. And there's nothing to say a derangement can't be there for 40 years.
Yeah. And does it matter the direction? I saw you going out. Does it matter if it's forward in front of you or if it's out?
I don't think so. I just, throw it out like this.
Yeah.
I don't think it makes sense.
It doesn't really matter.
Yeah, and you do it typically in supination. You do it in lateral rotation that way. I do it also in pronation, but in that case, I would be holding my forearm with pronation over pressure and then throwing it out. Whereas if I'm going to do it in supination, you can just throw it out that way. And I've certainly used both.
Mm-hmm. Supination more common than pronation? Or not really?
No, pronation more common than supination.
Pronation. Oh.
Yeah. And I think I talk about elbow and knee are brother and sister, and parents are the spine, and I take it even a little bit further. I go, the knee is like the lumbar spine, the father, less flexible. There's one lateral you really consider in the lumbar spine, side glide. Whereas in the neck, you have lateral flexion, you have rotation. That's like mom. And the elbow, you have a forearm rotation, but you also have lateral glide. And I always, for a long time, I honestly, randomly, if I went lateral in the elbow, I think, however I was feeling, okay, let's try pronation, or let's try this, or let's try lateral. I think I have better insight into that now, that on initial examination, if they do have painful supination, they're more likely to need, if they have to go lateral rotary movements, whereas if they don't have that, you're more likely to need lateral glide movements. So the initial examination, again, can help you with your management later down the line.
Mm-hmm. And do you find more common needing pressure on the elbow, like laterally or medially, or?
Well, lateral much more than medial when you need it, but I actually think I find myself doing more elbow lateral movements with forearm rotation rather than lateral glide. There's a classic Mulligan lateral glide for lateral glide into extension, and I certainly use that. But I think I find myself doing more pronation than lateral glide.
Mm-hmm. Okay.
But you have to remember, it's who walks in your door. I could say that, and then over the next month, I could have 5 elbows, and they all need lateral glide. You just don't know.
Do you have like a sequence that you do, or it depends more on like the history, like their mechanisms, that what prompts you to try one thing before the other?
Well, yeah, again, I think elbow and knee, I start sagittal plane like the spine. Mm-hmm. And you don't have the situation of like a lateral shift deformity in the lumbar spine where you know you have to go lateral first. That presentation doesn't exist in the elbow and the knee. I think so. There, the sequence is you start in the sagittal plane, hips and shoulders. Again, you've got extension and internal rotation, but there are times in the shoulder, anyways, that I don't start there and start with something else. In the hip, we'll typically start with either extension or internal rotation, typically extension.
Mm-hmm. Mm-hmm. And then just going back to the shoulder, when you're showing the ballistic, do you do the ballistic with the resistance?
Yes.
Okay.
There's some very short, stiff TheraBand at the top, and you have to back and forth wiggling it up there. Yeah. But again, that's an end stage. That's 80, 90% better, and I just have this little bit of overhead limitation.
Mm-hmm. And the resistance is always coming from the opposite direction you want to go.
I guess you could generally say that. So I mean, I think I definitely do more eccentric, but I think you can look at concentric as well. It's just that I look at eccentric and seem to get reasonable results with that. So I don't know. That's a point. Maybe I should spend more time looking at concentric, but generally it's eccentric. So if it's flexion, I got the band behind and they're pulling and then going back into it. Abduction, the same thing. Band is over their head. They're pulling out and then back.
Okay.
Yeah.
Okay. And how about horizontal adduction? Do you use the band as well? Do you find that helpful?
Horizontal abduction? Oh yeah, absolutely.
Yeah.
Absolutely. Yeah, that's a force alternative. And you can do the same thing. You can pull across and slowly eccentric, or you can work it fast at the end. I always do the slow eccentric first. And so you have the patient pull and then slowly back. And I'll often ask them that at the end of the motion, and the band is very stiff, to actually try to relax and let the band pull them even further. And, people ask, well, why does that work? Why does resistance work? And the honest answer is we don't know. Is it putting a different type of load on the joint? Yes. But is that why it works? We don't know. Is it doing something with motor control? Probably. I don't know, how to quantify it, but it's probably doing a little bit of both. And the more I do this, the more I'm convinced that motor control is a big issue.
Mm-hmm. And how about on the knee? Do you resist extension too?
Sure, you can do concentric or eccentric. You have the patient stand, put a small loop of TheraBand around the leg of a sturdy table, and they can face it, put their knee in the band and pull back against it eccentrically. They can turn and face away and do, concentrically, or they can turn and face away and do eccentric knee extension as well.
Mm-hmm. Okay. Any other tips for the knee? Because I saw you doing a lot of different combinations, internal rotation, external rotation.
Well, yeah, you can do rotation. I think that's hard to, in general, we look at tibial external rotation because, my sense is that the majority of knee derangements are due to a loss of terminal extension. And when you look at the knee, terminal extension is associated with tibial external rotation. So I think, it makes sense that you have to add that as a component motion. And that's a difficult maneuver to do, both in self-treatment, and there's a mobilization that you can do that's not terribly difficult. It certainly needs an explanation in practice. But I use that fairly often. It's certainly not rare that we use that. We use that pretty often.
Mm-hmm. And how about the load? Do you follow any logics for unloaded, semi-loaded, and then full?
The majority of lower extremity derangements, I believe, need to be treated in weight bearing. And I typically will only start non-weight bearing if there's a high pain level. The patient is very fearful, very acute, something like that. But to me, it's no different than how many lumbar derangements you lay down and you can go right to press ups. When you have the option of prone or prone lying and extension, a lot of times we skip those steps and it's the same thing in the knee. I might start with unloaded, but very often I start right away with loaded.
Okay. And I remember one time in one of Mark Miller's course, I remember him showing with the knee extension, like sitting with the band on the leg, resisting the knee extension that way too. Do you use that type of load as well, or do you usually do more standing?
I can't say that I've never used that, but if you ask that question, I say I do more standing. I do more standing. Okay. But again, this is one of those things that I can't tell you everyone needs loaded or standing. I think the majority do, but and that's okay as long as you remember that you have an option like what Mark showed. You can use that. Okay.
And how about wrists and ankles?
Wrists and ankles. Elbow and knee, brother and sister, parents of the spine. Shoulder are brother and sister, and then I always say wrists are weird uncles. They're just because if you look at prevalence, and I don't know the exact figures. I probably should, but it's something like 46% or 44% extension, 38 flexion. So it's very close. Number one. Number two, I don't see a lot of wrists. I mean, I see them on occasion. So I'm hesitant to talk a lot about it simply because I don't think I know that much about them. I'm not sure anybody does. It's just my thought is you go in there and you just start playing around to see what you're going to get. Mm-hmm. Yeah.
Traction.
Yeah, definitely. Traction. I think that's I do know a couple specific, mobilizations, manipulations of the wrist for very distinct presentations, which I don't think we really can get into in this forum. I do show them on the extremity course, but and one of them certainly involves traction. So in general, I am burned out on traction. I think traction is a wonderful thing to give you a temporary change, but as soon as you get, except for the wrist, and occasionally in the ankle, and maybe I should use it more, but I just, my experience is when I traction a joint, it almost always feels better, but I think most of the time, 10 minutes later, it hadn't really made a long-lasting difference. Now, traction combined with movement has a much better chance, but just straight tractioning, people will do call the glides for the shoulder and traction, just straight traction. I don't think they do a whole. That's my personal opinion.
Mm-hmm. Do you combine many movements, radial deviation, ulnar deviation?
Yeah, certainly you can. Again, starting with flexion and extension, then you can add in radial or ulnar. My thought is I tend to look at radial simply because functionally the wrist tends to do a lot more ulnar deviation in life. So I'm always of the mindset, well, if it does a lot of ulnar deviation and they're here, it means the ulnar deviation didn't fix it. Well, let's look at radial. So, and again, those are just my thoughts. They're not necessarily, I would hazard to say they're probably not widespread thoughts, and they certainly have no evidence behind them. It's just the way I look at things. So, okay. And again, I don't see, I probably see, one or two wrist patients a year, whereas I see, multiple knee and shoulder problems every week or month. Mm-hmm. Mm-hmm. Lots of hips. I mean, the big three is knee, hip, and shoulder. Those are the big ones.
And how about ankles? Any thoughts on it?
Well, ankle, if you look at prevalence, I think it's dorsiflexion. It's a little stronger than the wrist, but I think it's like 60-40 dorsiflexion versus plantar flexion. So I'll tend to look at dorsiflexion first. If you're not getting anything or worsening, then you look at plantar flexion, and you will use lateral movements, primarily eversion is lateral movement, and they need, again, to be treated and loaded. They typically need to be treated when you're working on ankle derangements. You want to be doing things with knee bent to take the long tissues out of the equation and allow the force best into the articulation.
Okay. And I was just curious to ask you, do you use like 90 degrees shoulder internal external rotation, or not very common?
Not a lot, on occasion. Not a lot. I know that's a favorite for most therapists. Most therapists are very keyed into external rotation. And I was along those lines long ago with stiff shoulders and pushing into external rotation and pushing into external rotation. And then I think I learned that there are better things than that. And I remember Robin saying to me, he said, an old Scottish physical therapy told me the two best things to do to most shoulders were either leave them alone or exercise them into internal rotation.
Mm-hmm. Following the same idea that they do a lot of external rotation functionally.
Yes. Yeah, functionally you do a lot of external rotation. And a lot of shoulder derangements, younger, healthier workout people, I have to caution them on day one. If it's here, you got to avoid this temporarily. You can exercise inside here, but I don't want you out here because you're gonna undo that reduction that we're trying to achieve. And it's only a temporary. But I see people literally reduce a derangement in their shoulder with 10 or 15 movements of internal rotation, and they reproduce the derangement with 5 pulls against a yellow TheraBand into external rotation, literally, just a few movements. And I show them that because they don't believe me that they shouldn't be out here. They want to be working. They want to be doing, overhead presses. They want to be doing, their squats with the bar right here. I'm like, well, you can't do that right now. And only temporary. And you see it on day one, and a week later, they can do 10 and they don't re-derange, but give them something a little stronger. So you can use that as a baseline to monitor progress over time as well.
Mm-hmm. And in terms of like time to reduce the derangement, like you said, that it could be really quick. And can you find that sometimes you need many, many reps through many days to Oh,
yeah. Yeah, it can. I mean, we talk about the hallmark sign of derangement is rapid change. Well, I'm but I think I'm confident to say extremities tend to be hyper rapid change. They change very, very, very quickly. Now, nothing's 100%. Some of them need a lot more reps over time. But I routinely see people that make dramatic changes in their extremities on the first visit.
Mm-hmm. And how many reps do you give them to do as homework?
Oh, it depends on what we saw in the clinic. I mean, if it takes 30 in the clinic, it's going to take 30 at home, right? So, but the classic 10 every 2 hours. I don't often advise extremity derangements every 2 hours. I usually say every 3. So 5 to 6 times a day. And that's based on the thought in the spine, if your directional preference is extension and you're flexing 4,000 times a day and you're flexing to end range, literally 100 times a day, you can easily undo that. But if you think about it, if your directional preference for the elbow is extension, how often do we actually go to end range flexion? We don't. We are in flexion a lot, but it tends to be mid-range. So my general thought in the extremities is we don't do as much of the bad as we do potentially in the spine. So they don't need that same type of frequency. They still need to do it frequently, but not every 2 hours is 8 times a day. Extremities, I generally tell people, and do this about 5 times a day, every 3 hours.
Mm-hmm. Okay. And I know we are almost running out of time. just any considerations about contractile dysfunction in like general terms, anything that you would...
Well, yeah, I think there's, a lot out there. Our recent conference, we had talks on ankle and shoulder, and, there's a number of different promoted loading strategies, concentric, eccentric, slow, heavy resistance, isometric, once a day, twice a day. Nobody's been proven that absolutely one approach is universally better than any other approach. But I think what people agree on in general is that you need to progress slowly. The speaker at our Ottawa conference, she said she tells her Achilles patients, you can expect that it's going to take 1 year. It takes a long time to improve these tendons. And again, you have to go slow. You have to be careful not to overload. They need to be consistent. If you're going to do it once a day, you got to do it once a day. So I think those are just general guidelines. And part of that, the difficulty is, especially a lot of these people, younger, more active, is trying to convince them that they need to go slow and that it is going to take time because they're impatient. They want it to be better, right away.
Yeah. Scott, if people want to learn more about this topic, any recommendations of places that they could look for?
Yeah, if they haven't, they need to take Part C and D, and then they need to get credentialed, and then and you don't have to be credentialed, but you need to take at least Part C and D and then go to an extremity course. And we've got some incredible extremity instructors, and it's not just me. Mark Miller, him and I started this together. So he doesn't teach quite as much as he used to, but he still has just an immense amount of experience. So Mark is ultimately valuable. Gary Dykes in Georgia is excellent. Dave Oliver has taught numerous extremity courses and is well versed in extremities. And then we have some other folks that have more recently began instructing the course. Christy McGuire, Chris Chase, and they're both excellent. So I don't think anybody looking to take an extremity course should be, well, I'm going to want to do it with that instructor as much as, well, this is the one I can get to the soonest. That's the closest that works for me, and go to it, because we all do the same thing. We still in the United States treat more patients on courses than arguably any other country, with the exception of probably France. France, I know they still treat lots of patients on stage, and I think that's essential. I think you can talk about this stuff all day, but it doesn't mean nearly as much as when you see it in practice with a patient right before your eyes. Yes,
absolutely. And Scott, if people want to contact you or reach out to you, is there a way they can find you?
Sure, but I caution, and I do even say this on courses. I can't treat your patient. It's very difficult when I have a patient who has this and this and this. What should I do? Well, there's just so many. Well, what happened when you did this? Did you try this? How did you do that? How often? It's virtually impossible. I'm happy to try to help people out, specific questions, but again, and there's also, at least in the U.S., a legal aspect to trying to treat somebody else's patient over the internet. So again, I'm happy to consult with people, but not directly about individual cases.
Yeah.
And I'm not trying to be, forget the legal stuff. My experience is it's virtually impossible because I don't have all the information. And sometimes it's that one little bit of information that lends itself to finding the answer.
Mm-hmm. So many details, as you said, the position of the arm. We were talking about the horizontal adduction. If you do it a little bit more flexion, little less flexion, so many details on execution. It's very hard.
Right. And to try to describe, well, did you try it here? Or did you try it here? Or did you try it here? I mean, again, that's a good example. But I can tell you this: in the diploma program in our classroom, on the whiteboard, but in permanent ink, we had listed the four sins for MDT clinicians, especially those in that initial stage of learning. But we're all always learning. But it's number one, not getting to end range. It's so terrible. I mean, in the extremities, it is not a visual assessment. You have to ask your patient, are you feeling strain? Are you feeling strain? You got to be getting strain. Number two, you touched on this, not enough repetitions. Number three, and I didn't bring this up, but we do use in the extremities lots of static loading. So I'll have the patient do 10 repetitions and then sustain the last one for, say, 30 seconds. The last shoulder I saw yesterday morning, the woman got horizontal adduction against the wall with a lot of pressure, and on the 10th one, she was to sustain it for 30 seconds. So we do use a lot of sustain both in the spine and the extremities. And then lastly, changing your treatment direction too quickly, not being thorough enough with one direction, looking at all the possible progressions and force alternatives before you just start jumping around to all sorts of other movements. You need to be thorough with whatever movement you pick. You need to be thorough before you go on to the next one. So I think that's general advice for people out there who want to send an email and say, I have this patient, and then say, okay, try all those things first.
And now I have to ask you, so when you put static load, we haven't talked about that one. Is there like a rationale, like when they don't get 100%, you do that in the end? Like how
it's we don't know the actual, physiological or biomechanical, whatever you want to call it, explanation. And this is true. Patients ask, they say, why did that movement work? And I just say, well, it's because of the right movement. And I say, well, did that push my disc back in? Sure. Did that straighten out my pelvis? Sure. Whatever they want it to be, because I don't know that is or isn't true. And I don't need to get into a discussion or I don't need to tell them what they're thinking is wrong. But if you say, no, it can't, then you're essentially saying, well, you can't get better. So sure, that movement does whatever you want it to do. The only thing I really know is it was the right movement with the right load. Okay, good. And what happens, we don't know. So sustained, again, is just another force alternative. And the general progression in the spine is you get your direction, you add overpressure, patient overpressure, you do more reps, and then the next thing you can do is sustained. Then you could also look at ballistic, you can look at resisted, you could look at loaded versus unloaded. You have all those options. So sustained is just another option.
Yeah. And is there anything that prompts you to do sustain or static, or is just...
Well, sometimes the patient says, geez, when I get it all the way there, the pain is gone. And then when I come back, the pain comes back. So essentially they're getting abolish, not better at end range. Well, their shoulder is saying, I like being over here. Well, then let's put it over there and keep it there.
Yeah.
It can be as simple as that. Other times it's, well, I've done 100 of these and it's 30% better, but I'm not getting more better. Oh, well, let's just try this and see what happens.
It seems so logical when you say it.
So sometimes it is. So I would say the one time for sure you want to try it is if you get abolish, not better at end range, sustain the whatever you're doing at end range. It's, just, hey, so the person is getting, the scapula shuts off back there. Put them in prone sustained extension end range.
Yeah. Yeah.
Mm-hmm. Their spine is saying, I want to be back there. Okay, well, let's put it back there and keep it there for a period of time.
Yeah. Makes sense.
Yep.
Very logical.
This
makes
stuff
more sense than you're explaining.
Yeah. Miller and I used to sit there and we'd be talking and say, how in that? McKenzie was such a genius. He figured this stuff out. It's like, how did he figure this stuff out? And I still think about that to this day. To say he was a genius. He just very logical. He went through it, and he put it together from nothing. It's just truly amazing.
Yeah, and that's what when you are explaining and saying, like, okay, the positions you spend more on the day than usually are the ones, the opposite that you need. So it makes all sense. It makes total sense, but we don't put it all together.
Yeah. And again, it's for a lot of people, I think in the extremities, it is you have to have confidence in the system. You have to trust the system. And it is the same in the spine, but most people, more people have more experience with the spine because that's where MDT started. So they have that confidence, and then they get to the extremities and they don't have that same level of confidence. So they don't tend to be as diligent and persistent with their management, and they need to be. Yeah.
Scott, thank you so much for your time. I really appreciate you coming here, taking the time, sharing all your knowledge, experience, your 40 years of experience with the system and the extremities. It was great, amazing. I learned a lot. I think everybody, the audience probably learned a lot with you. Before we wrap up, anything else that you want to add?
Nope. I think that, again, I encourage people, and this has been an issue within our organization for literally decades. We have so many people take A, and the majority go on and take B. And then after B, there's a big drop off in the number of people that go on to C and D. I think the thought is, well, I got the back, I got the neck, I got this. And the reality is you don't. Most people will have told me, and I know others hear this as well, that things for learners really start to come together when you get to part C. That pulls the spine together, and then you get that introduction to extremities, which opens up a whole new world for you. So I encourage, if there's anybody out there who's taken A or maybe taken A and B, and they're unsure of, should they go on? Yes, absolutely, because that's when you really start to understand this stuff. That's when you really put it together and again get the extremity stuff, which is so exciting. I see things every day that still, even though I've seen it maybe 500 times previously, it's still amazing to me to see that, to see the look on somebody's face, and they're just like they're like, what is this, magic? And I'm like, well, sort of.
Seems so simple, right?
Right. A lot of people are confounded by the simplicity. Well, that can't work because it's too simple. Well, no, sometimes the best solutions are the simplest solutions. They're not necessarily the most complicated solution.
Yeah. Awesome. Well, that's great. Again, I just want to thank you, Scott. I appreciate you taking the time. It was a wonderful discussion.
All right. Thank you. You're welcome as well.